everyone. Thank you for attending day 2 session of headache series, which is endorsed by Emmons. Today, the talks will be done, fortunately and unfortunately, by me, the first talk, and the second talk will be done by Dr. Yusri. I have to take this opportunity to send my deepest and sincere condolences for the death of Dr. Yasser's father. Dr. Yasser, you will be remembered, and your dad will be also remembered in our prayer in this difficult time for you. And therefore, I will be doing Dr. Yasser's talk today. The first talk would be the local experience of migraine headache during COVID pandemic in this year. So our main talk would be the local experience for migraine management and migraine severity during COVID-19. So this slide was prepared, as I said, by Dr. Yasser, but I'm doing it because of his father's death. Next slide, please. Okay, so why are we talking about migraine? So migraine is a debilitating disorder which imposes a high social burden and so impact in the activities of daily living. So migraine is one of the leading cause of years lost with or years disability in MENA region and also in worldwide. Migraine is more common in female, of course, as usual for other diseases. We divide basically simply migraine to episodic or chronic, depending on the number of days. If you have a migraine less than 15 days per month, then you call it episodic. If it's more than 15 days per month, for more than 3 months, then you call it chronic. So the migraine prevalence is usually around 10% in the global population. Next slide, please. So the epidemiology of the Gulf countries, the few countries were studied the epidemiology, and they found out that approximately in countries like Saudi Arabia, it runs from 5 to 10%. And countries like Oman and Qatar and Kuwait recently has been done, it's mainly around 10%. Obviously, tension type headache is more than migraine, but we don't see them a lot in the clinic because they treat themselves. Next slide, please. Okay, so migraine constitutes one of the main disorder which causes disability and loss of activities of daily living. Next slide, please. Okay, so also migraine is among the 10 top disease which causes a combination of death and disability, like other diseases. Next slide, please. Okay, so as we mentioned here, the burden of migraine in UAE and other countries is very high. Imagine if the migraine headache is around 10%. So in the population of UAE, it would be around 1 million. So 1 million people who are suffering from migraine headache. So that's a population of local in UAE. So that's equal 1 million. So that's a lot of activities or a lot of lost days. Next slide. So going through the COVID backwards, so we know that the first COVID case was around January 2020 in UAE. And at that time in DHA, Dubai Health Authority, we started declining the clinic visit. And in around February, we implemented distance working. The curfew was implemented partially in March, and it was full-time in April. Next slide. Okay, so we know that for the fact that COVID is or causes neurological manifestation, and among the neurological manifestation is headache, and they usually present with severe headache, and it's calculated around 10 to 20% of people with COVID present with severe headache, and those people who present with neurological deficit. Next slide, please. Okay, so the research illustrated that is a headache cause of consequence of wearing a mask, or people who do have headache present with more headache symptoms. It illustrated that PPE can induce headache in 80% of the population, or the people who are in frontline, healthcare givers. And people who have pre-existing migraine, headache, primary migraine, 91% of them come with headache. Next slide, please. So as we know here in epidemiology of COVID in UAE, the burden was increased, or the number was significantly increased around April, and even the death was increased. So that was the first breakthrough or breakout. Next slide. Okay, so what measures did we take to organize our clinic, especially migraine clinic? So we implemented a telephonic clinic with telemedicine clinics. So we were calling patients and communicating with them on their number of headache and how many headache they are having. We were restricting them not to come, and if they need to come, they have to come to clinic directly as opposed to going to emergencies. They were triaged clearly for the people who are having severe status migrainosis. They will come directly to the clinic and they will get treatment. So the therapies or the medication were put online, and the patients were going directly to the pharmacy to get the medicine, or they were getting medicine by home through home delivery. The injections, that CRGP antagonist, we were getting it at home as well. We were avoiding direct exposure, so medications such as occipital nerve block, sphenopalatine ganglion block, and botulinum toxin were avoided during this period. We were canceling them for triggers. We were explaining to them to avoid stressors, especially those who are sitting at home and having kids. Most of them, they may be exposed to stress and they may have more headache. Next slide, please. So as we see here from the numbers, the number of personal physical visits were reduced during the COVID time here, and the number of telephonic clinics were increased during the time of COVID, and it picked up recently as we opened more and more clinic in August. Next slide. Okay, so what we did here, we wanted to make sure what's going to happen with migraine, and what's going to happen with the severity during the COVID period. Would the severity be affected? Would people with migraine become more? Will have more? We studied, or we reviewed approximately 840 patients. Out of them, only 201 fulfilled the criteria, and obviously, female were more dominating the disease, because we know that migraines are more common among females, and the age group were between 13 to 71 years. and most of them were Arab ethnicity. And fortunately, none of them were contracting COVID. Next slide. Okay, so surprisingly, what we found, so what is MIDAS? MIDAS is Migraine Inventory Disability score. So the higher the number is, the worse the migraine is. So we have a few parameters. We assess how many days the patients are affected at work and how many days our patients are affected at home, and how many days the patient are having headaches. So these numbers are counted all together and collected. So we noted during the COVID period, actually the MIDAS score or the migraine severity were reduced by a significant number. And that number continued for the rest of the year until we calculated in November and December. Or November, sorry. Next slide. So as we said here, the migraine severity score were reduced from 25 days or from 25 to 18, and the number even continued to be low from March to May. The headache days were on average 6.7 days before the COVID. During the COVID were around 5 to 6.4 days. So the number of headache were reduced by approximately 1 day on average. The mean severity score of the headache were reduced also from 7 to 6.6 and 6.4. The people were using less and less abortive medications. So on average, the people were using 5.3 abortive medication per month and were reduced to 4.7 medication per month. And the number continued to be reduced in March and May as well. Emergency visits were significantly reduced by at least 50%. The triggers of migraine were also reduced. Obviously, because we counted that stress from the work were the major triggers here. Next slide, please. Okay, so what kind of medication or prophylactic medication were used during the COVID? Pretty much same one. 90% were using prophylactic medications. And among the prophylactic medication were propranolol, amitriptyline, topiramate, CRGP inhibitors. 58% showed good compliance, and only 31% did not show good compliance. And it was mainly because most of them ran out of the medication. Patients who were using monotherapy did show much better outcome in terms of tackling the headache and headache days compared to those who were taking combination treatment. Next slide, please. The reduction of the MIDAS or the migraine severity score was noted among those who were taking preventive medication. Next slide, please. So things which need to be attention should be taken to confounding factors, and those would be the existence of stressors such as social stressors. People imagine a single mother or a mother who are sitting at home with a migraine and their kids are at home. Imagine the amount of stress they're having. Even though with those stress, their migraine severity were reduced during the COVID period. Next slide, please. So here we can see the number of the migraine or MIDAS score, which were reduced significantly during the COVID period. Some of them picked up after in May to March or March to June, but it wasn't significant as it was pre-COVID time. Next slide. So if we are calculating the trigger factors during these 3 periods, pretty much the trigger factor was the same, except for the workload. Of course, the workload, if you are working at the work, is more than when you are working at home. So that was the only difference which we noted. Otherwise, the other stress factors were more or less the same. Next slide, please. So in summary, we experienced significant improvement of migraine severity score from period 1 before the COVID time compared to period during the COVID time. The confounding factors were put into account despite having the confounding factors with the stressors. Despite all these and despite the uncompliance, still though the migraine severity and the migraine days, headache days were much less during the COVID time. So that's a significant observation. Next slide, please. So what did the advisory board recommend during the COVID period? What to do? So the clinic visit, we encouraged, or the advisory board encouraged telephonic or telemedicine, rather calling patient than bringing the patient in physically. Pay attention to red flags. If the patient is having red flags, bring the patient to the emergency or to the clinic and do the necessary tests. Remote screening of COVID should patient have severe headache and or headache, which is unusual to their common headache. Next slide, please. So you can use abortive medication, but I would avoid medications such as, which is imposing direct exposure, such as occipital nerve block, sphenopalatine ganglion block, botulinum toxin injection. Next slide, please. Preventive medication can be used. Botulinum toxin can be postponed, and ACE inhibitor were avoided because it was thought to stimulate COVID. Next slide, please. So what are the common medication were used during the COVID era? Pretty much same medication were used. Acute medication, they were similar one, and NSAID, triptans, lasmiditan. Neuromodulation can be used if the patients have to come physically and the patient is having severe headache. And despite giving all these conventional medications, the patient are not improving, then you may need to use conventional neuromodulation such as occipital nerve block or sphenopalatine ganglion block. Bridging treatment, there were no change. Symptom-specific treatments such as amitriptyline, neck massage, magnesium are welcomed as well. Other acute medications such as intranasal, dihydroergotamine and ergotamine, sphenopalatine ganglion block are welcomed in acute should patients still have headache despite giving conventional medication. Other preventive medication were more or less the same and nothing were avoided. Next slide, please. So in conclusion, so despite all the risk and stressors, migraine patients showed good outcome during the COVID. Maintenance of habitual lifestyle and distance working during pandemic further supported. We encouraged, based on our finding, we encouraged change of paradigm to upgrade our therapeutic approach of migraine treatment and utilize telemedicine and telephonic medicine more and more during COVID, and maybe we need to use it more in the future. This is the end of my slide. Thank you very much. Shifting the gear, we will put the questions till the end of the talk. Next talk would be done by Dr. Yusri Salah Shafiq, and the topic would be on undiagnosed headache. Dr. Yusri is a specialist neurologist in Mediclinic City Hospital. He is, His main interest is in stroke and headache. He has been graduated in Egypt, and he had his training in Egypt as well. Dr. Yusri, welcome, and please go ahead.
Thank you, Dr. Abu Bakr, and my deepest condolences to Dr. Yasser. We hope that he can join us, but unfortunately for what happened to him, so deep and sincere condolences to him. Thank you, Dr. Abu Bakr, for this great chance to have me with you here, and thanks a lot also for Dr. Sohail for giving me that good chance. Good evening, the attendee. Today I will present a presentation about the rare types of headache or undiagnosed headache that we are facing in our clinic. Today the presentation will be more practical, okay, how to go directly to the to diagnose the headache. So first we will start to speak about rare types of migraine. We know the migraine that usually we are used to see it in the clinic, but now I will speak about the rare type. So one of the rare type of migraine, it's migraine with brainstem aura. The old name it was basilar migraine, but recently they changed the name of it to migraine with brainstem aura. The migraine with brainstem aura usually it has no particular gene association, and it's different than the hemiplegic migraine which runs in family. Here it can run in family, but we didn't find any genetic association like familial hemiplegic migraine. The difficult thing with this type of headache that how to differentiate it, especially in the first attack, because the differential diagnosis is very important, because it will make a great difference in the treatment of the patient. So the most important differential diagnosis is transient ischemia, transient ischemic attack, which is one of the great mimics for the basilar for the brain migraine with brainstem aura or the familial hemiplegic migraine. So how we will differentiate it? First, the young age of the patient, then slow spread of the aura. In the TIA, it will become all of a sudden, and it will stay for 20 minutes, 15 minutes, up to 1 hour. But here in the migraine with brainstem aura, the aura will take longer time to spread. It will almost take about from 5 minutes up to 60 minutes to be completely. And the headache usually happened after the brainstem aura. Then the repeated attack, of course, it will manage to direct us to the diagnosis. So we need at least 5 attacks. Each attack have at least 2 of the following: any brainstem manifestation like dysarthria, vertigo, tinnitus, hypoacusis, diplopia, ataxia, or decreased level of consciousness. Here we don't have any weakness, so it must be away from the weakness. So these 7 presentation are presentation of brainstem aura. So it will start gradually. It will spread over up 5 minutes up to 60 minutes. Then the headache will come after this. The aura must not extend for more than 72 from 5 to 60 minutes, and it should be completely reversible. Then we will speak about the hemiplegic migraine. So the difference between the hemiplegic migraine and the migraine with brainstem aura. The migraine with brainstem aura, we don't have any signs of weakness. It's only brainstem manifestation. But here the hemiplegic migraine, it must run in family, or it usually run in family. Very few sporadic cases are reported in the literature. So, and we have also a gene here, which is calcium CNA1A gene, which is include the BQ voltage gated calcium channel 4, and it's account for more than half of the inheritance 4. We have other gene, the familial hemiplegic migraine type 2 and familial hemiplegic type 3, but the most common one is the familial hemiplegic migraine type 1, which is responsible for encoding of the BQ voltage calcium channel. And this also, we will find this gene is common in the episodic ataxia also. So when we have a person with familial hemiplegic migraine, we should ask about the episodic ataxia, because it's common correlation, because it's all of them are presented on the same gene. Here, how to diagnose it? We need at least 2 of the following of the 4 characteristics manifestation. First, aura spread again over 5 minutes. Each non-motor aura should not exceed 72 hours. At least one aura symptom must be unilateral, and the headache will follow by 60 minutes. Again, it's very important from the first attack to take all our precaution and not to rush in this diagnosis, because it be difficult in the first attack. But if there is a repeated attack with normal brain imaging and no risk factors of the patient, and the presence of the strong family history, this means that we are dealing with a case of familial hemiplegic migraine. We are speaking about the last rare type of migraine, which is retinal migraine, and sometimes it's difficult to differentiate it between retinal migraine and migraine with aura. But the gold standard differentiation between both of them is the unilaterality of the aura. So in migraine with aura, the aura changing sometimes on the right, sometimes on the left. Maybe it will have more preference to one side, but it's alternating between the right and the left. But here, retinal migraine, it's confined, it's restricted to one side only. And it should be differentiated from the transient blindness, especially the amaurosis fugax. So when I have a patient with unilateral retinal migraine, which is the aura only unilateral, we must check for the carotid artery, we must check for the ophthalmic artery, just to make sure that we are not dealing with any differential diagnosis or any ischemic event that can affect the patient vision. Then, so we spoke about the rare types of migraine, which is migraine with brainstem aura, which is familial hemiplegic migraine, and the retinal migraine. Then now we will speak about another correlated entity to migraine, which is the trigeminal autonomic cephalgias. Trigeminal autonomic cephalgias are a group of headaches that have sharing some criteria. These group of headache are cluster headache, paroxysmal hemicrania, hemicrania continua, short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing, and short-lasting unilateral neuralgiform headache attacks with cranial autonomic features. These headaches are associated with one or more cranial autonomic symptoms. So these kind of headache are sharing these presentations, such as ptosis, conjunctival injection, lacrimation, nasal congestion, or rhinorrhea ipsilateral to the pain. And how to differentiate between all of them, because all of them are sharing the same criteria. So it's very important to differentiate between each type of them, because each type of them has its specific approach and specific treatment also. So we have a rule here that the frequency and the duration. So as long as the frequency increased, this means that the duration will be shorter and the name will be longer. The frequency are less, the duration are long, the name will be shorter. So if we speak about short Sanket Ursuna, we have the highest frequency but shortest duration of attack. Then we have the whole continuum ranging between the frequency and the duration. We need more and more practical differentiation between all of these types. So we will go for the second slide. Here, this table containing how to differentiate between all of them, but we need also, because in the clinic the time is short and we need to be more concise and more targeted toward the diagnosis. So first we will speak about the duration, one of the most important things. So when I have a patient with a headache, this headache is strict, unilateral, and duration not more than 180 minutes, I mostly deal with cluster headache. If the duration are between 30 minutes up to maximum 45 minutes, maximum 1 hour, I'm speaking about paroxysmal hemicrania. Less than this, I'm speaking about the short unilateral neurology form headache. Hemicrania continua, it must have that I have a baseline headache. So between the attacks, here the patient is free, but here the patient has a baseline headache. Then times of exacerbation where the autonomic manifestation will appear, which we spoke about. This is the time of this is the duration, and then the number of the attack. Usually cluster headache, maximum time 8 attacks, but usually we can see up to 4 attacks. Paroxysmal hemicrania, it's more frequent, but the most frequent one is the short unilateral headache with conjunctival tearing. This up to 100 per day. The hemicrania, as we spoke, usually we have a baseline headache, then at times of exacerbation. All of them, as we spoke, sharing the autonomic manifestation. Then also sometimes we found some people that they have overlapping between the duration and sometimes between the frequency, as we can see. So we will come to the next associated manifestation. One of the most important associated manifestation that characterize the cluster headache is the restlessness. The patient of the cluster headache, he cannot stay calm, he cannot lie down, he cannot just standing like this, holding his head, he cannot, because even his wrist, it's contrary to the migraine rest making him more relief or decrease the pain. But here the rest with the cluster headache patient, it make the pain is more, so he must move, he must roaming around searching for any pain killer to reduce such a severe pain. It's the severest type of pain that any person can experience. And also one of the most important criteria for the cluster headache, it's reaching up to the ear. So the patient with the cluster headache, he's telling that it's a strict unilateral associated with the autonomic manifestation that we spoke, not more than 180 minutes, not more than 2 hours, we can say. And also it's associated with restlessness. The patient during the attack is restless. So if the patient told me during the attack he is restless or not, if he told me that no, I'm just restless, trying to relax, trying to calm down, so we are away from the cluster. But if he told that no, I'm restless, I'm agitated, I cannot sit down and I cannot stay in one place, so this means that we are dealing with the cluster headache. Then when we will speak about the circadian rhythm cluster headache, we have nocturnal attack. So we need to ask the patient about this manifestation. It's restlessness during the attack or no? It's awaking you from sleep or no? Because as we can see here that all the other headache, they don't have this nocturnal attack. So it's one of the most important differential diagnosis or characteristic of the cluster headache. Then we can come to about what trigger this type of headache. Usually when we have a headache that triggers by the neck movement or cervical root pressure, mostly we are dealing with paroxysmal hemicrania. As we can see, the hemicrania continua, it's just only continuous headache. We have a baseline headache with times of exacerbation. This is one of the most important criteria for it, that the patient between the attack is not free from the headache. And here the short unilateral lasting headache, only cutaneous manifestation can induce the headache. Neither the cervical root pressure, maybe the neck movement can experience it. So if we spoke about the type, the frequent, the attack of the attack duration, and if we speak about the timing, and if we speak about the nocturnal attack and the triggers, I think we can differentiate all of them within the first visit, because one of the recent studies showed that cluster headache, usually the first patient to get diagnosed from the first clinical visit, only 21%, and it needs up to 1 year to diagnose most of them as a cluster headache after doing a lot of investigation. So if we didn't ask, we will not find the question, and we will treat all of them as a part of migraine. So we need to ask, we need to emphasize about these certain criteria so we can reach a rapid, a quick diagnosis and definite diagnosis from the first clinic visit. Then here in the paroxysmal hemicrania, one of the most important criteria, which is not with migraine and also not with cluster, that the patient will feel that he has burning eye, or she has burning eye sensation. It is not pain. We must differentiate burning eye from the pain around the eye or the orbit, which is in most of them or all of them. But here the patient is telling that I feel that I have a sensation of greedy sensation, I have a sand sensation, I have pepper sensation in my eye. So we must ask about this. If he gave us this diagnosis, this means that we are dealing with paroxysmal hemicrania. Then we will speak now about the practical tips that we can, I know that all of you know this, but just as a reminder, as long as these types of headache are very rare, so we need to obtain an MRI scan and pituitary testing once we get to reach this diagnosis, just to rule out any other secondary mimic. Migrainous feature may accompany the trigeminal autonomic cephalgia, but they are more likely to be ipsilateral to the pain versus to bilateral in migraine. So it's one of the most important criteria to differentiate that migraine is sometimes coming one time left, one time right, maybe bilateral, but here it's strict unilateral, more to the ipsilateral. In the treatment of the cluster headache, it's better to start the short-acting verapamil instead of the long-acting. Usually, verapamil causes heart block, so we must be sure that we have a baseline ECG and we have started gradually increasing the dose every 2 weeks. Usually, when we are treating a patient with cluster headache, it's better to start a bridge therapy until the verapamil and until the taking its up titrated dose until it to reach the good effective dose. So we need at least to cover our patient by a bridge therapy. Usually the bridge therapy here either prednisone or either dexamethasone. We can use it up to 2 weeks regularly until the verapamil dose is up titrated to a good effective dose. When we are treating a cluster headache, usually we prefer to avoid the oral form because the patient, because of the severe pain, because of the type of the pain, because of the associated autonomic cephalgia, so the gastric manifestation are making the patient difficult to take these oral medication to stop the attack. All the patient with cluster headache must be given a trial of oxygen, but this trial of oxygen, it had the requirement that we need high flow rate, 10 to 15 liter per minute. Nasal cannula will not work, and we must give through non-rebreather face mask. If we have a woman with a cluster headache and doesn't have any circadian periodicity, think that we are dealing with paroxysmal hemicrania, because paroxysmal hemicrania more in female, but cluster headache is more in male. Cluster headache and the short unilateral neuralgia form, conjunctival tearing are more occurring in men. Paroxysmal hemicrania more likely to have chronic temporal pattern. Paroxysmal hemicrania and hemicrania continua are one of the indomethacin responsive medications. So if we have a patient with diagnosis of hemicrania and hemicrania continua, indomethacin must be offered to the patient because it carries a good therapeutic effect, and also it will help in diagnose him by the dramatic improvement of the headache. To diagnose hemicrania continua, we should have low level of headache required before and associated with time of exacerbation. A sensation of foreign body, this is what we spoke in the differential diagnosis in ipsilateral eye reported the hemicrania. But if you don't ask, again, you won't know. Indomethacin response may delay up to 2 weeks. If I have any patient with strict unilateral headache, it's better to give him a trial of indomethacin. Headache that only respond to high indomethacin doses or require frequent doses of escalation, it's better to look for another cause more than the hemicrania continua or paroxysmal hemicrania. Usually when we are treating the patient with indomethacin, it's better to cover the patient with the proton pump inhibitor. So if the indomethacin is not suitable for our patient or side effect developed, what other alternative we can use? We can use melatonin and the greater occipital nerve block can be used instead of indomethacin. How we will differentiate the short unilateral neuralgia form with conjunctival tearing from the trigeminal neuralgia? Usually the trigeminal neuralgia taking V2 and V3 here, it involves V1, the longer duration of action, longer than the trigeminal neuralgia. The frequency of the attack, also the associated cranial autonomic features, which is not in the trigeminal neuralgia. Also lack of refractory period, which is there in trigeminal neuralgia. And lamotrigine is the drug of choice for the short unilateral neuralgia form headache, followed by topiramate and gabapentin. So as we saw that it's very important to differentiate the type between the types of the trigeminal autonomic cephalgia, because each type has its specific medication. If we started it early, if we offer the patient to start it early, so we succeed to control the patient pain and to reduce his suffering. Now we will speak about another rare type of headache, which is spontaneous intracranial hypotension. Spontaneous means that it didn't follow a trauma, it's spontaneous, it didn't follow a spinal tap, it just is spontaneous. How to suspect, why to suspect, is it important or not to know, how to diagnose? So spontaneous intracranial hypotension results from CSF volume depletion, nearly always from spontaneous CSF leaks. Spontaneous intracranial hypotension nearly always results from a spontaneous CSF leak at the spinal level. A spontaneous leak from the skull base cribriform plate occur only rarely. So we know that now it's spontaneous leaks from the spinal level. From the skull base, it's very rare. So the most common clinical manifestation of spontaneous intracranial hypotension is orthostatic headache. A headache occurring while the patient is in upright position, that is relieved in recumbency. So when we are dealing with a patient of a headache which is chronic, which is occurring for a long time, and lack of the autonomic manifestation, which we spoke in the trigeminal autonomic cephalgia, so we need to ask our patient, we need to tackle this area, that your headache have any orthostatic relation, it's more on standing, more on sitting, more on lying down, there's difference between the headache severity or no. It's often bilateral, dull aching, pressure-like sensation, and the location is variable, sometimes frontal, sometimes fronto-occipital, sometimes holocephalic, sometimes occipital. So we can, if we have this change in the position regarding related to the headache, so we need to ask about the other manifestation about the spontaneous intracranial tension. Again, if I'm not putting this in my mind, again I will miss this and I will not ask. So what to ask? One of the most common association is the cochleovestibular manifestation, that tinnitus, but it's non-pulsatile tinnitus, and the change in the hearing. They will tell, as we can see, that it's muffled, distant, echoed, distorted, decreased. So and dizziness, vertigo, lightheadedness, rarely Meniere-like presentation. As we can see that if someone just told me that I have muffled hearing sound, okay, so what about the headache? It's very important to ask. Then what about the position to relation? It's very important to ask, because if we will take only each one alone, it's again, we will miss. We need to combine all of them together not to miss this. Also, one of the most important thing that it will help us, that the nausea, which is often also orthostatic associated with the headache. So when I have the headache, when I'm standing up, I have the headache and associated nausea. When I'm lying down, the headache and the nausea are less. Sometimes we have a diplopia or visual symptoms associated to the related to the sixth cranial nerve palsy than the third or fourth cranial nerve palsy. In the advanced stage or in the chronic stage, we might have some cognitive, like the memory difficulties. We have also gait unsteadiness. We have sometimes movement disorder, but this is an advanced stage. So why it's important? It's important because it has a lot of complication if left untreated, and the patient, to diagnose him by this diagnosis, of course, it will take long time and need a lot of investigation just to find why he had this headache. And sometimes after the usual MRI, we might miss, or CT, or the usual CT, we might miss. So it's very important to tackle this area during the clinical evaluation for the patient. So what is the most common complication of untreated spontaneous intracranial hypotension? Subdural hematoma, rebound intracranial hypertension, cerebral venous thrombosis, and bilateral brachial amyotrophy, and syringomyelia. Syringomyelia, it will occur because of the herniation of the tonsils, of cerebellar tonsil, and compressing the brain stem. So because of this, the syringomyelia will occur. So it's very important to recognize such kind of headache. How to investigate? So from the clinical picture and from the associated manifestation, we start to suspect about this. So how to investigate such kind of headache? MRI of the head of the spine, this is the major abnormality, will include diffuse pachymeningeal gadolinium enhancement. So the MRI, when we have a suspected patient like this, should be done with contrast. Sinking or sagging of the brain, descent of the brain stem, subdural fluid collection, and enlarged pituitary, and engorged venous sinuses, and decreased size of the ventricle. The investigation of a choice is radioisotope cysternography. This is the radioisotope choice when coding the radioisotope cysternography. We are injecting the radioisotope scan, and we are measuring taking at interval of time how come it will, how much it will, or how long it will take to reach the brain. So, and within 24 hours, the radioisotope scan must reach the vertex. CT myelography, this is the most reliable test to show the exact site of leak. In the next slide, I will show you some images explaining all of these. So here we can find the subdural collection on both sides from the complication of the spontaneous intracranial hypotension. Here we can find the pachymeningitis enhancement, and here we can find the engorgement of the cerebral venous vessels. This is illustration for the radioisotope. Here the normal. Here we are injecting the radioisotope, then it will take almost 24 hours to reach the vertex. Here we can see the different types of leak, and here we can have the meningeal diverticuli, and here we can have the meningeal tear, which is the site of the leak. Here, this is the CT myelography. We can see the enhancement of the root, and we can see the meningeal diverticuli. Here we can see the brain stem, here the beginning of the spinal cord. Here we can see that we have extradural collection of the fluid. It's clear here the spinal cord, here the CSF. We have extra arachnoid collection of the fluid, which means that we have spontaneous intracranial hypotension. So we spoke about the very important types of headache that we need to keep in our mind, because it will make a great difference with our patients. The rare types of migraine, the trigeminal autonomic cephalgia, and the spontaneous intracranial hypotension. For the time being, I have here almost 10 types of rare types of headache, but most of them are benign. But also, it's better to take one scan if the headache didn't respond to the first line of medication, just to be in the safe side. Thank you a lot. Thank you, Dr. Abubakr. Thank you for the immense to have me today with you. Thank you a lot.
Thanks very much, Dr. Yusri. It's a very illustrative talk. Housekeeping issue, just to remind all the audience, we reached almost now 800 participants. That's a very good number. We have CME. These sessions are CME accredited and will be sent to you by email within 2 weeks' time. Even though the talks will be recorded and be sent to you as well. So back to questions and answers. We have 21 questions. We'll divide it to each other, Dr. Yusri. So
it's my pleasure.
The first question would be answered by me. What's the treatment of intractable post-COVID headache? Usually the intractable post-COVID headache is like other meningitis headaches. You treat it accordingly. So you treat the COVID with the medications, and usually those headaches are usually intractable. And if it becomes intractable, you may need to use prophylactic medication as you use for migraines. And for most of them, they may improve or they may not improve. But the mainstay of treatment is to treat their COVID. From your data of migraine patient during peak of pandemic means fear of the COVID, it seems, specify. Well, what we found that the migraine severity score are less by at least 30 to 40%. I attributed this mainly because most of people, migraineurs, were residing at home. So those people who are residing at home, they're having less stress, their work environment is less, and therefore their headache are less. So therefore I believe their headache became less. But they had other stressors as well. So if they were mothers, they have their kids at home, and they may contribute to increasing their headache. Despite all these factors, the headache was less during COVID period. That's what we noticed on 200 patients. What medicine for migraine was not available to patient? Well, because of the COVID, we were avoiding direct contact. So anything which requires patient's presence, like botulinum toxin injection, or occipital nerve block, or sphenopalatine ganglion block, where we inject lidocaine to the nose, those will require patient to be present, and that requires also risk. And that entails risk for the patient and the doctor, because you're exposing patient with the medication to the nose. So therefore, the AHS expert did not recommend these medications. Hypoglycemia during Ramadan increases severity of migraine. Of course, I mean, many people come back, many people with migraine, they come more frequently during Ramadan time because fasting may trigger their migraine, and sometimes hypoglycemia as well. And sometimes non-compliance to their prophylactic medication may contribute to increasing their headache. So that question might be answered by you, Dr. Yusri. Trigeminal tax headache is very common. What is the best treatment? I think you answered this in your talk, but you may need to.
Shall we go for one? This I saw hypoglycemia during Ramadan. You answered this, Dr. Abubakr. Shall we give more than one prophylaxis drug and intranasal lignocaine arrest migraine attack?
No,
and how much time?
Trigeminal TAC headache is very common. What's the best treatment for TAC headache?
The trigeminal?
Trigeminal autonomic cephalgias.
The trigeminal autonomic cephalgia. The trigeminal autonomic cephalgia, as we spoke, we need first to differentiate which type. But usually, if you can, because the most important thing is to pick up early cluster headache, because the approach, the new medication, the new medication for it, the Emgality, all of these are, it's better to tackle it from the beginning to pick up it. But if it is difficult to differentiate between the other three, I think it's better to offer the indomethacin first.
Okay. Are you able to read the questions, Dr. Yusri?
Yes, I can. I'm reading this, but I think it's not in order.
Okay. I could pick one. How much incidence of TAC and cluster headache? What do you mean? What's the incidence of TAC and cluster headache?
The incidence is very low. It's 0.1 per 100,000 person. It's a very, very low incidence, but we need to keep in mind to pick it up early.
Lots of CSF leak cases associated with skull-based surgery. What is the best treatment for such headache?
First, we need to diagnose the site of the leak. It's very important, especially if we have a surgery. So it's better to go for the types that we spoke about. Then the other different modalities of the treatment will depend on the site of the leak. So if the site of the leak is spinal, it's better to inject the glue material or the colloid, crystalloid, or the blood patch just to cover the leak. But if it is in the skull base, I think it will need again surgery to put a glue on this leakage area, so it will not leak again, so the headache will stop. Or we can use the other conservative medication like caffeine, a lot of fluids, and abdominal binder, just to read the intra-abdominal pressure, trying to giving the time for the meninges to heal by itself. But I think all the literature telling that it will take longer time, and the result of it is not 100% sure, like the closure by the glue material.
Okay. I had an interesting question here. Is it scientifically proven that listening to classical music would help to reduce a migraine? Well, anything that reduces migraine, any training that can help reduce a migraine are good to be used, such as good sleep hygiene, yoga, certain what's called relaxing exercises may help to reduce migraine. But is it scientifically proven? I'm not sure. I'm not aware about this. How about you, Dr. Yusri? Are you aware of any studies done that?
For the relaxation, I don't have a solid data about for how long it's used, for how many patients. I don't have this solid data. But as you told Dr. Abu Bakr, that of course it will give anything that make relaxation, it will give help to the migraine.
Okay. So someone asked about the duration of prophylactic medication in migraine. Usually the duration is 6 to 8 months, but it can be prolonged depending on the patient's severity of headache. What I do usually, I keep them for 6 to 8 months as per studies, and I try to taper it slowly if the patient headache severity and headache days reoccurs again, then I will reinstitute it again. So depend on patients and individual patients. But if you're depending on the studies, usually the studies are done for 6 to 8 months. So this question, that's an interesting question. Is there any relation between hair loss and headache? Dr. Yusri?
I don't have any information about the correlation between these, except in the psychiatric people with the trichotillomania. Maybe this is the only information that I have, but clear information now.
I'm not aware about any data stating that there is evidence, there is relation between those two.
Yes.
There's another question here. People who are having night duties having more chance of migraine. Is it true or not? Yes, the answer is true. Any stress may provoke migraine. Social stress, sleep stress, night duties. So people, sometimes those who are having very severe chronic and daily headache due to night shift duties, I exempt them for a few months, and meanwhile I treat them with prophylactic medication. Then we reinstitute the night duty again and see how they react. But most of them, they don't tolerate night duties. I agree. And is there any link between eye muscle imbalance and migraine? The questions are becoming difficult.
Yes.
Yeah, I mean, in my opinion, eye strain of people who are having astigmatism and nystagmus, they're having amblyopia or reduced vision, they are at risk of having tension type of headache. But if they are having underlying migraine, and of course, this may trigger it. What are the safest drug to be used for migraine? We answered this question yesterday. Usually paracetamol is the safest drug. If it's second to third trimester, we can use NSAID and brufen. As a prophylaxis, we can safely use Inderal if the patient is having intractable headache. And sometimes I use medications such as sphenopalatine ganglion block. So I inject lidocaine intranasally or occipital nerve block, which are pretty much safe in pregnancy. I think, Dr. Yusri, we finished all the questions. There is one question for you. Is there any chance that hemiplegic migraine can be misdiagnosed with mild stroke?
Especially in the first attack, yes. In the first attack, when we are facing a patient with transient weakness, and the complaint will be transient weakness for 10-15 minutes, then now I improved. So the first light come to our mind, the first thought come to the mind that it's a minor stroke. But I think when we are doing the MRI and there is no even single spot, there is no risk factors, all the stroke workup came negative, plus the recurrence of the attack, I think it will be clear in the future attack that we are dealing with familial hemiplegic migraine. But of course, from the first time, it's very important to deal with it as a TIA instead of dealing with him as hemiplegic migraine.
There's another question here. Is hemicrania continua without autonomic symptoms common?
Usually, all these types of headache are very rare. But usually, we diagnose the hemicrania continua if we have a baseline headache with exacerbation of the autonomic cephalgia. But if we have a hemicrania without exacerbation of the autonomic cephalgia, it's written in the literature, but it's again more rarer than the more than the hemicrania with autonomic cephalgia. But all of them are rare disease, not common.
Yeah, of course, if you have symptoms without autonomic symptoms, then you may need to exclude other causes such as pituitary pathology.
Yes.
Or
yes, it's very important.
But sometimes I do see some patients without autonomic symptoms, and they do respond to indomethacin, and it's been reported, as you said. Let's see, we can hunt for more questions. What is the aid or home remedies for headache or migraine? Well, there are a lot of home remedies we can use. You can use herbal medications such as riboflavin, feverfew can be used, magnesium sometimes. Sometimes you can use cinnamon to help your headache. Some people rub their head in order to alleviate their headache. Simply, if you have migraine headache and you're improving with resting, just go to a room and rest and close the light. For many people, it helps.
I think Dr. Abubakar got disconnected. He can also check the questions, Dr. Yusri, on our Q&A tab.
Okay, I think we answered all of them. And I can see here all the questions in front of me. Dr. Abubakar, I think I don't have any other questions to be answered. Are there any legal regulation for employees who work affected by migraine attack? I think the best one to answer this question is Dr. Abubakar regarding the legal issues with the migraine people. What is the subcutaneous injection for migraine? We have the somatriptan subcutaneous injection. We can use it especially if we have the patient that is rapidly developing migraine. So the aura is coming, then immediately after it, within less than 5 minutes, the headache hits. Then again, the rapidly developed headache, then the nausea and vomiting occurs early. So the patient, if he even succeed to press himself and to swallow the oral triptan, it will not also offer help. So the best thing here, either the subcutaneous injection or the nasal spray to give him a rapid help and to avoid the nausea and vomiting that he is suffering from.
Dr. Abubakar is now rejoining.
Yes.
We also have one question here wherein, are there any legal regulations for employees whose work affected by migraine attacks?
Yes, this is a question. I think it's best to be answered by Dr. Abubakar. He had a lot of information about this issue.
Okay. One more question here. Do you think the lockdown and the present situation causing stress might be a causing contribution to the increase of migraine?
Usually, stress and anxiety, lack of sleep, disturbed sleep pattern, any kind of stress can be a trigger for the migraine, especially during this hard time that all the world face. So, with each individual with his own stress, own burden, own load, of course, it will aggravate the migraine. But he should have migraine before so to be aggravated, but it will not be the cause, but it's a triggering factor for the migraine.
Thank you. And what is the safest drug for migraine after cesarean labor?
This answered by Dr. Abubakar according to the and after cesarean it's usually We prefer if the patient will go for breastfeeding, so we have limited options. One of them, the magnesium, the riboflavin, we can use them safely during the breastfeeding. But after the breastfeeding, we return back to the no restriction, so we can use any of the medication in our hand according to the patient number of attack, patient style, risk factors. All of this will determine which type of medication we can use.
Please continue,
I
Dr.
guess we
Abubakar.
finished most of the questions here. My apologies, guys. I got disconnected. I think we finished the Day 2 headache series. And thank you everyone for attending this meeting. There was huge number attended yesterday and today, and I'm very glad for having this meeting successful. And we're going to continue this in future, inshallah. Just to remind you guys, the CME points would be sent to you by email. It's 2.5 CME points. And the record will be sent to you as well. If you have any questions, of course, you can always ask the organizer. Thank you very much and goodbye, everyone.
Goodbye, and thank
Thanks,
you, Dr. Abubakar, for such a great chance. Thank you, all. Thank you.
Thank you, Dr. Yusri. Thank you, Dr. Abubakar.
Thank you, all the attendees. Thank you.